You will know the better one so
so I in my yam kirabe be me wa. You will know the better one so
so worry, and my tip and you will know. You will know the better one so
The title of my presentation is Primary Healthcare, using a people-centered approach to health in its renaissance. For those who do not know me, I'm Eugene Kongnyuy. I'm an obstetrician gynecologist. I'm also a global health consultant. I'm the professor of global health in Euclid University. So I work now with the UN. I'm in Mali right now, but before then I was a clinical lecturer in the University of Liverpool in the UK. So what is primary healthcare? It all started in Alma-Ata. Alma-Ata is a town in Kazakhstan in 1987, where all countries of the world met, and after examining the progress that have been made, they concluded that primary healthcare was the right thing to do and call on all countries to adopt primary healthcare. And they outlined the 7 elements of primary healthcare. For those who went through Qs, they are familiar with Professor Lantum. He used to teach public health, and we will talk about the 7 elements of primary healthcare. Education for health problems is water and sanitation, having adequate and clean safe water and basic sanitation. The treatment of common diseases and injuries that are found in the locality. I would like to insist on the primary healthcare means that any disease that is common within the community is included under primary healthcare. So it is determined by the diseases that are present. All diseases common in the locality are considered under primary healthcare. Only those ones that are not common, things that are rare, that are sent for specialized healthcare. Maternal and child health, vaccination or immunization, prevention of endemic disease. These are like endemic diseases that we have in Africa, like filaria and other like that are there. And the availability of medicine, drugs for the treatment of this disease. This was the basic definition, and this definition has actually not changed, apart from a few changes when 30 years after. So in 2018, the world met in Astana. Astana is another town in Kazakhstan. Kazakhstan has been the center country that is focused on primary healthcare, with the WHO Director General being from Ethiopia and convinced of the importance of primary healthcare, took the world back to Kazakhstan, this time to Astana, and they examined the primary healthcare. He is keen because Ethiopia has succeeded in primary healthcare. They talked of primary healthcare as a whole of society approach to health, entire society approach to health. So it is the development approach to health and well-being centered on the needs and preferences of individuals, families, and communities, and identified 3 key elements. They talked of a comprehensive range of care throughout lifespan. So primary health care is not limited to a few things. It's not limited to prevention, as some will say. It includes curative, rehabilitative, and palliative care for common diseases and injury. Anything that is common is considered primary health care. And it systematically addresses broad determinants of health beyond the health sector. I can say that this is where the current definition has a slight change from the definition in Alma-Ata, because these determinants have been expanded. In Alma-Ata, they were limited to nutrition, water, and sanitation. But now they include anything outside the health sector that will affect the health of people is considered these broader determinants that need to be included in primary health care. And empowering individuals, families, and communities is not different. Is what is one of the three the elements that was mentioned in Arma attack. To take control of their health, either as self-carers, they self-care, they care for themselves, or caregivers caring for other people, or co-designing the health services, or being advocate for better policies of health services. So communities need to be empowered. Now, so why is primary health care important? This is the photo of Shisong, certainly. It's effective. We know that 50% of gains in reducing maternal and child mortality between 1990 and 2010 were due to factors outside the health sector. We also know that all African countries that achieved the Millennium Development Goal, and there are not many of them, there are about 3 of them, we had strong primary health care. All those countries that didn't adopt primary health care didn't achieve Millennium Development Goal on health. We know that it is also cheaper because we focus on simple things, screen and prevent, and treat early before they ever reach the hospital, so that few are sent to hospitals. And it covers about 90% of the healthcare that we need. It is also has wider benefits. The benefits go beyond the health sector, including reducing poverty, hunger. If people are healthier, they can work better, they can farm. If they are well educated, have clean water, it addresses climate change and gender equality. So it has wider benefits than just within the health sector. Now I try to look at the health sector strategy of Cameroon, 2016 to 2027. And this is an extract from this document. At the end of a thorough analysis based on data and conclusive indicators from our health profile, the strategic option, which set out the guidelines of our health strategy for the next 12 years, has been adopted. It brings together 2 major health approaches, namely the primary healthcare approach, whose impact on the beneficiaries is no longer to be determined. Is no longer to be determined. They confirm that they don't need to determine. And the more complex, specialized approach, whose service provision will be considerably improved. So it means the Cameroon health sector strategy identified 2 strategies. The primary healthcare, which will cover 90% of the healthcare needs, and the complex specialized care that will cover the rest of the 10%. Okay? And when we look at still the health sector strategy, looking at community action. Community action here is referring to what I mentioned as one of the 3 components of primary healthcare, which is about empowering individuals, communities, and society. They listed what it means by community action or community empowerment. It means that the community need to participate in health care financing, which Dr. Gilbert just talked about. There is the participation of representatives of communities in co-management. I would like to signal this because in Cameroon, we believe that there are village health committees that are managing. I will tell you that is not enough. What they are doing is because they have not seen how this is properly managed. This is not managed. They are just participating in some sort of management, but they are not really managing the health facility. I can tell you. Advocacy, communication, and social action by civil society organizations like the Schumans. Services of community health workers. We don't have community health workers in Cameroon, and this is the core of primary healthcare. Community initiative for promotion of health. So these are the actions which will ensure that we empower communities to participate in primary healthcare. That's why primary healthcare, if you ask somebody who has been in Cameroon healthcare for long, he will tell you that Cameroon is practicing primary healthcare. But that's not true. I can tell you, after seeing what is happening in other countries, I'll tell you that Cameroon doesn't have a, Cameroon has the first component of primary healthcare. The second is weak, and the third is almost completely absent. Okay, this is the table that Gilbert was talking about, which I would like to interpret. I already interpret. Thanks to Dr. Bernard, who is my nephew. He shared with me. He's the medical officer in Kumbu district. So he shared to me this Excel sheet that show where our health centers are, and I went through it. That the categories of health facilities in Cameroon are divided into 6 categories. And that in SAW, we have category 4, 5, and 6. We don't have 3, 2, and 1. And that in SAW, we have 4 category 4 hospitals, which is the hospital in Jakiri, the Kumbu District Health Service, BBH, and Shisong. First of all, my interpretation, as I said, is that BBH and Shisong are classified by the government, but in practice, they are not category 4. In practice, they are operating as either category 3 or 2. Because I've worked in BBH during when I was in Cameroon, I worked in Shisong. I know what they offer. I know what is offered in general hospital and in queues and all that. I know what is there. They are operating as 2 or 3. And sometimes they are operating as 1 because the cardiac center in Shisong is in category 1. It is very highly advanced. So now the Kumbu District Health Service is not even category 4 because it is something that people do not go there. But they put it as category 4, but actually it is category 6. That is the funniest thing, that we put it like that. Nobody knows that there is a hospital in Tokyo. No one goes there, but it's put as 4. That is the deficit that we have in our health system, where government puts structures and they are not manned. They don't have the infrastructure, but they give a name to it. And in that way, we are not receiving the support from the government that we ought to receive. Even the one in Jakiri, I know it. I'm from Jakiri. I know the hospital in Jakiri is not even up to category 4. It is really like a CMA, like category 5. So the population of based on the data still owned by the government, is that we have 143,700 people, of which 59,000 are in Kumbu West. Kumbu West include Kumbu and then every part that is up north Kikai and going up, and including BBH, and Kumbu East includes Shisong and down towards Jakiri and all that. There are 83,900 people in that health district. And then we have 3 medicalized health centers. The one in Jakiri has a hospital and a medicalized health center, imagine. Then the one in Kumbu, which is still the one in Tobin. So Tobin, there you have 2 things. The Kumbu Health District, which is there, and CMA, which is there. And they give there are 2 health facilities in Tobin. That's rubbish. And then they have the Mbiame, the Mbiame, which is closed, is not functional right now. And there are 289 integrated health centers. So this is the majority are the integrated health centers, which do not have a doctor. The difference between medicalized and integrated is that medicalized has a doctor, a general practitioner, and the integrated, they don't have a doctor. Okay, but I wonder whether there are 2 doctors in Jakiri. I'm not sure. There's only 1 doctor which is in the hospital. The CMA has no doctor. So those are things that are in paper, but they are not actually functional. All right. Now the health system in SAW, the excellent thing that we note is that we have 2 tertiary hospitals, the BBA and Shisong. that provide quality and affordable services. But we have some weaknesses. There is suboptimal quality of services at the primary and secondary level. All those government health facilities, the services are suboptimal. Individuals, families, and communities are not empowered to optimize their health. As self-carers, as caregivers, as co-designers of health services, or advocates for better health policies, we don't have that empowerment. We pay out of pocket. BEFA is there to support, but I bet you we pay out of pocket for most of the time. Ignorance and harmful social and cultural practices are there that still hold us back. Communication and transport. Just imagining, even from Jakiri to Kumo, where there is a main road, it's not easy. It's not easy. Then imagine villages that are deep inside where there is no road, what they are doing. We lack resources, human, medical supplies, and infrastructure. So these are weaknesses in our health system. We have the strength, but especially at the primary and secondary level, they are very weak. So I would like to briefly talk about primary health care, which is people-centered. It's all about people. And people, I will use the acronym people to describe what we need to make primary health care work in South. P for partnerships, E for empowering communities, O for other services, P for paying for services, L for leadership, and E for essential services. I will take just one after another to explain what we need. If we have it, we'll make primary healthcare work in South. For partnership, we need government-private partnership, and even partnership with civil society organizations, NGOs, and all. Because the government partnership involves two partners coming together, each bringing what it has, its comparative advantage, and there to the partnership. The government will bring the infrastructure. The government already have 280 something health facilities in South. So the facilities are there. The government needs to equip them and man them, provide the personnel that work in them, provide the medicine and supply. Those are things that we need to advocate for the government. But the community has many other things that can bring on the table. Co-management of health facilities. The village health, I call it community health committee because the village health committee is not for one village. It is for several villages. So I just call it community health committees. Need to manage the health facility properly. We'll see how they can do that. And community has resources. There are platforms like Jangi, the Chong, the Fu, the Samba, the market, the churches. Those are platforms that the community has. It has people, has labor, has transport, communication, has the money. The community can co-finance. What DEFA is doing, the community is co-financing services, is financing services. And we have people in the diaspora who can also support. And the community has the knowledge of socio-cultural determinants of health, so they can know how to maneuver around it. The government doesn't know. The community knows better. So the outcome of this will be a better health for the population. It is a win-win. So we need to build a partnership with the government and let the government do its part and the community does its part. Okay. Now, empowering communities. To empower communities, I just highlight one of the things where we have an army of community health workers selected from within the communities and trained to serve the community. Like in Ethiopia, this could be women who just got married and they are in the village. They are not going to go anywhere for the next 20 years. They are trained to serve the community as community health workers. And their functions will be to move, for example, from door to door, raising awareness on health issues, education on health issues, providing basic services like family planning, and referring difficult cases to the health center if needed. They will organize health talks in the market, churches, villages, jungle houses to talk about health issues. They will go to school to talk to teachers, to tell teachers what they need to teach the people and teach the students based on, we need health literacy and so. They will map out all households and their health needs. How many children are in each household? Are they vaccinated? How many pregnant women are there? Are they going for antenatal care? How many people are taking medication in chronic basis? Are they taking their medications? They follow up. They report to the health center on a weekly basis, like it's done in all countries with primary healthcare, Ethiopia, Mali, and all the like. Say Friday, they come and present their data to the health facility that this is what they are seeing. They identify model households. In Ethiopia, they have identified model households, and the model households are households that have made certain standards of health. And those model households, they have a flag. They have a flag that if you are passing, you see the household, you know that this is a model household. It is a privilege to have that flag before your door to show that you are the lead in health in that community. And they lead others, they talk to others, encourage others to meet the health standards, the minimum health standards in that community. In Ethiopia, for example, there is one community health worker who covers 20 households. In Mali, one community health worker covers 1 to 3 villages. So in Ethiopia, there are more than 30,000 community health workers. There are many more health workers in Ethiopia than in Mali. They cover just a few households, and they know everything that's happening there, and they visit them regularly to see how they're doing. And these community health workers, I encourage that they should be paid by the government. This is what we can advocate for and tell the government that your policy is talking about primary health care. We need community health workers, but we need you to pay. In countries that have community health workers that are voluntary, it has not worked. So I won't encourage. Maybe you can start voluntary, but I won't encourage to have community health workers for long who are not being paid. They need to go to government payroll, or at least some way they need to be paid. The other sectors. The other sectors are also part of primary healthcare because they impact health. So primary healthcare applies a community development approach to health. The community health workers, for example, they will go to school. Now they are outside the health sector. They are talking to teachers. They are talking to people. They are teaching teachers what to teach the people and students. They teach families about nutrition, about safe water and sanitation. They talk about environmental health. In Ethiopia, they talk about how to separate families from animals so that they don't contract animal disease. Their work includes collaboration with their counterparts, like in Ethiopia, they work with agriculture. Agriculture has other people who look like community health workers, but they work in agriculture, teaching people how to do the agriculture. So they work in close collaboration with them. Community health committees, we need also to take an integrated approach to health, not just limited in health. While they look on health issues within the health sector, they will seek support from the council. The council can recruit people and put in a health facility like it's done in Mali. They will also look at issues outside the health sector that affect the population. Those issues should be brought to the attention of the South Development Association or the local equivalent and to the council so that they are addressed at the broader picture of community development. Now, this is what Gibe talked about. I prepared a slide or two on this, which I would like to bring to attention of the 4 types of health financing and which of these is suitable for us. We have the tax-based financing, like in UK. Tax are levied on goods that people buy. And where you pay for any goods, whether you pay for a hotel or anything, you have a tax in it that go to health. This type of system, some consider it to be one of the best health financing system because people pay according to their means. If you are rich, you will buy more things than the poor person. There's no doubt about it. So the more things you buy, the more tax you pay, because tax is levied in any small thing that you buy, which goes to health. So it is fair. It is a fair tax system, but it has a condition. We need to have a good tax collection system, no corruption. So most African countries, this cannot work because there is a lot of corruption and the tax collection system is not working well. So that is out. The next system is the social insurance system. It's the one in France, and I think it is also the one in Germany and Italy and many of the European countries. Payment is deducted. Payment for the insurance is deducted from the people's salary, and when you work, they deduct automatically. This works very well where many people have formal employment. But if you come to Africa where many people have no formal employment, it becomes a problem, because you will have few people who are paying for the tax and then taking care of the rest of the population. So it is estimated that we need at least 80% of the population to be in formal employment. Southeast Asia have adopted this system, but in another way. I will take South Korea, for example. South Korea adopted social insurance system. Knowing fully well that many people in South Korea are in informal employment, they put conditions. They don't deduct from the salary, but the government gives the tax that you have to pay based on the value of the house which you have, the value of your car, and the amount of money that you have in your bank account. You will agree with me that if you are a rich person, you cannot have little money in your bank account, you are living in a very poor house, and you are driving a very poor vehicle. That will not work. So this is a fair way of trying to say, well, rich people, they are going to so they ask people to pay, and the amount you pay is based on these three elements. The third one is private insurance. It's the one in the US. US has private insurance for adults, but for the elderly, there's Medicare, which is the government. The private insurance has a problem in that the aim is to make money. And so the money for health keeps soaring because doctors keep prescribing anything because they know the insurance will pay, and they are paid based on how much you spend and all the like. So the money keeps soaring. America spends 25% of the national budget on health, but still is one of the worst developed countries in terms of mortality, because of this. Community health insurance, which we talk like BEFA, is like a private health insurance, but it is designed not to make money. That is a good thing. But both community health insurance and private health insurance have a problem. Most people will not subscribe to it if it is not mandatory. The best we have for voluntary community-based insurance is 10% of people subscribing to it. Most people do not. If you just ask them and tell them, explain insurance is good, go and subscribe, they will not do that. It has not happened. Countries have tried across Africa, it doesn't work. And the last is out of pocket. Although there are BEFA and other things in Cameroon, majority of people pay out of pocket. So the dominant is out of pocket, which is the worst form of payment for health services. So when you look at this, you start wondering, how on earth are we going to get health insurance in Cameroon? Which model are we going to? Let us look at what has worked and in some countries. So a few countries in Africa have succeeded in health financing. These are Mali, Ethiopia, and Rwanda, for example. Majority have not succeeded in anything. The private health insurance has all failed. Even developed countries, even America has failed. It has not worked. Community health insurance has not worked in many countries because people are not willing to subscribe to it. Okay? The best voluntary community health insurance, as I mentioned, only 10% of population is like the one. What BEFA is doing is similar to what happened in one district in DRC. The best across Africa, 10% of the population will subscribe. So I will expect that the best that BEFA will achieve will be 10% of the population subscribing to it, not more. So what has worked so far? Two types of successful community health insurance have worked in Africa. The mandatory community health insurance, the one in Rwanda. Rwanda has the mandatory community health insurance where the community, you are supposed to pay an amount of health insurance. If you don't pay that health insurance, you cannot get into the market in Rwanda. You cannot get your child enrolled in school in Rwanda. They will check whether you have the insurance card. Few people who cannot pay are identified by their village, the village head they identify, and then send their names to the government, and they are exempted from the insurance. Apart from those few who are extremely very poor and cannot pay, everyone is obliged to pay. There is no exception. The second one, which has worked, is community-driven community health insurance. It is community-driven because it comes from the community. It is managed by the community. It is different. It is different from an insurance where you try to convince people to subscribe. I will show the Mali type and you see. BEFA, like BEFA, is community health insurance, but you try to convince people to subscribe to it. It is not driven by the community itself. So that's where the problem is. In Mali, for example, community-driven health insurance. Each community health center has a number, it covers a number of villages. And each community health center is managed by a community health committee, which we call a SACO. And each village is represented into the health committee by a representative. All villages that the health center cover are represented in the health committee. And the health committee asks each village to pay an annual insurance amount based on the number of households that the village has. And then the representative of each village in the community health committee takes the total amount to the village and present it to the village, and they divide it among the household, and then the household contribute. The household, when they pay, they have a card for that household. The contribution is put in one pot and used for service provision. So families that pay get a card and are entitled to free emergency transport from the health center to the hospital. They are entitled to free services and medicines, or some of the services are not free, but they are on a reduced price. You pay only 25% of the cost. The government also subsidizes this system. The medicine that is provided by the government and some supplies provided by the government. So that is what is written, and it is come out of the community. This system is different because once they take it to the village and everybody is paying, they give pressure to any, there's some sort of peer pressure in this type of system. Because you can't be in the village and then everybody is paying and then you say you are not going to pay. You understand? And everybody is paying and contributing to it, so almost everybody goes in and pay. Now, the next one is leadership. Leadership is about the community health committee that provide leadership for the primary health care at the community. As I mentioned, membership of this committee include representative of all villages, and the only person in the health center who is member is the head of the health center. And the president, it is led by the president and members of the executive committee. And the president are connected in the network. So if we had one in Bush, there will be a district federation of community health committees, and the regional, including every committee in Bamida, regional health federation of regional health committees. They participate. The importance of participation in this is that they share their experience and learn from each other, because if each village health committee is locked on its own, it doesn't know what the others are doing. They may not be doing the right thing. So what is their function? They manage the health facility, including its financing, buying and selling of medicine. They recruit additional staff to fill the gaps if needed, to the gaps that are not filled by the central government. They assess the overall performance of the health facility and take major decisions. They investigate and take decisions on complaints such as fraud, bribery, theft, staff performance. They assess the performance of community health insurance, community health workers. They can ask the government to replace a staff of a health facility who is not doing well. Maybe the doctor in the health facility, they can say they don't want the doctor. They look at broader issues outside the health sector, issues like water and sanitation, nutrition, and bring them to the attention of the bigger bodies such as Development Association or local equivalent, or to the council, and ensure that it is addressed. This is the last slide. Essential services. So essential services have not changed from the definition in Amata and Astana. These are services that are comprehensive, ranging from promotive, preventive, curative, rehabilitative, and palliative services, and span from children, teen, adult to elderly. And the services are provided both at the community and in the health facility. What makes us decide whether the service is a primary healthcare service is whether it is common or not. Any disease that is common within the community is considered under primary healthcare and should be managed as such. Services are rooted in social justice and the recognition of the fundamental right to the highest attainable standards of health by everyone, as stated in Article 25 of the Universal Declaration of Human Rights. So, this is the photo of BBH.
So